Great. Hello, everyone, and welcome to today's live discussion, Tackling the Youth Mental Health Crisis, which is part of the BHI Collaborative's Overcoming Obstacles webinar series. My name is Sam Lewin-Smith. I am a program administrator here at the American Medical Association and will be moderating today's discussion. Before we get started, a few quick housekeeping items. Please note that this session is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. You can also find relevant resources to today's discussion in the related content box on your screen. Lastly, if you have any general questions or concerns, you may send them to practice.sustainability@ama-assn.org. During today's discussion, you will hear from experts regarding the ever-changing mental health landscape for children and adolescents and how physicians and their care teams can address these mental and behavioral health concerns in their practice. After today's discussion, participants will be able to understand the changing landscape of the youth mental health crisis, promote mental health and wellness among children and youth, utilize screening tools for identifying and diagnosing youth mental health concerns. And it's now my pleasure to introduce our speakers. Joining us today are Dr. Arwa Nasser, Professor and Division Chief of Academic General Pediatrics at the University of Nebraska Medical Center and Chair of the AAP Committee on the Psychosocial Aspects of Child and Family Health, and Dr. Joanne Young, Clinical Professor in the Department of Pediatrics at the University of California, San Francisco, and Senior Associate Director for the UCSF Child and Adolescent Psychiatry Portal. We are going to now start the interview-style discussion with our two speakers. And the first question is actually for Dr. Young. What can you tell us about the youth mental health crisis landscape, and how has it changed over the course of the pandemic?
Good question. So what we know is that even before the COVID-19 pandemic hit, there was a rising rate of youth anxiety and depression and other mental health conditions. So in 2018 to 19, just before the pandemic, 1 in 6 American children ages 2 through 8 had a diagnosed mental, behavioral, or developmental disorder. And among adolescents ages 12 to 17, over a third reported having persistent sadness and hopelessness, and 16% had made a suicide plan, and this is pre-pandemic. And again, among children ages 6 through 17, anxiety and depression rates were already increasing from about 5% in 2003 to 8% in 2011 to 12. And what we also knew about the epidemiology was that the rates went up as age went up as well. So older kids were at much higher risk for having anxiety or depression compared to younger kids. So then the COVID pandemic hits, and we get the latest data indicates an acute worsening. So in 2021, the CDC data indicates that 42% of youth, American youth, ages 12 to 17, reported feeling persistently sad or hopeless, and 29% reported being in poor mental health. 22% had seriously considered attempting suicide, and 10% had actually attempted suicide. Okay, so pretty grim numbers, and they're even worse for female students. So among female students, almost 60% reported that they experienced persistent sadness, and nearly 25% had made a suicide plan. And among LGBTQ students, that number hits nearly 70% reporting persistent sadness and hopelessness, and nearly 25% attempting suicide. So you can see the gender difference here on the slide. It's high for both and increasing, as you could see, over time, but significantly worse for girls in terms of depressive symptoms. And going on to the next slide, you can see some of the gaps here broken down by race and ethnicity. Again, an upward trend for pretty much every racial group here, but particularly high for multiracial youth, followed by Hispanic youth, white and African American youth. And so going on to the next slide, we can look at the suicidality rates. Again, worse for female students than for male students, but increasing for both, but particularly for the girls. And moving on to the next slide, broken down by race again. You can see, again, that same trend, generally upward for most, not as steep a climb but worse again for multiracial students, followed by whites and African Americans.
Great. Thank you for that overview, Dr. Young. Dr. Nasser, is there anything you'd like to add?
Not really. I think those numbers speak loudly and speak for themselves on the volume of this problem. And I think anybody who is practicing pediatrics certainly has seen those trends really in real life.
Okay, great. So this next question is for you, Dr. Nasser. How has the youth mental health crisis that was just outlined shown up in your clinical practice? What have you experienced? What have you seen? What has your care team experienced to date?
So as I mentioned, and as Dr. Jong mentioned a little bit ago, this trend has actually been observable in clinical practice before the pandemic. We've been observing an increased level of mental health problems in children and youth for the past 15, 20 years, and it's been increasing. I think that the more recent attention to this issue actually has allowed more people to come forward and bring those up to the doctors than before. So we do see those definitely in practice. We see them as we see children for their well visits and screen for mental health problems. And also as we see kids for all kinds of symptoms. Some of them are directly mental health related, such as academic underperformance, clear symptoms of anxiety or depression. Somatization is also a common thing. We see kids with headaches and abdominal pains that when we explore further, and also some of those have already been proved by studies to have strong behavioral mental health underpinnings. So we do see those on regular basis before even, I don't know, I think the literature from 15 or so years ago documented that about 30% of all primary care visits have some kind of mental health component. If you ask, and about half of those come in specifically with a mental health complaint, chief complaint. So again, they are common. We see them very frequently, and I know that a lot of pediatricians are seeing similar trends, and this has also been shown by studies, and are really looking for ways to try to help those children.
Great. Dr. Jung, anything you wanted to add to that about what you may have been experiencing in practice as well?
I've definitely been experiencing this in practice, as a number of my patients were having panic attacks and couldn't go back to school. When the schools were starting to reopen, high rates of depression and suicidality. I find myself doing suicide risk triage and assessment all the time as part of my clinic. It seems to happen pretty frequently now. And I think underlying that, there was a certain amount of social isolation that was feeding into this, and social anxiety. And I want to reiterate that I don't think COVID caused all this so much as it intensified a trend that was already happening, exposed it for the world to see. And if there's a silver lining, it's that it became more acceptable to talk about youth mental health issues, and youth themselves felt freer to bring this up, and parents, I think, were a little bit more willing to engage. I think that is the silver lining here. I also started getting more requests for stimulant medications. Parents who were never willing to medicate their ADHD child were suddenly interested. So that was another thing that I saw come popping up in my clinical practice.
What can primary care providers in pediatrics do about the crisis when they're encountering it in their practice? How can pediatric PCPs get involved? Dr. Young, do you want to start?
So if we could just actually pull up that next slide, I want to show this map. And I just went over some pretty astonishing numbers of youth depression, suicidality, and mental health need. And I think what this map shows us is an equally astonishing workforce shortage, a real lack of child and adolescent psychiatrists across the country. So those states pictured in red are severe shortage areas. I must have lost signal for a moment. Internet's not cooperating with me today, but these are severe shortage areas, which means that there are not nearly enough child and adolescent psychiatrists to meet all this youth mental health need. So those of us who are used to identifying and then referring on just find that we can't really do that. And the numbers are even worse for developmental behavioral pediatricians. So that means primary care really has to step up to the plate. There is no way that we're going to be able to address this critical need, this critical healthcare need for our patients, unless we increasingly move into spaces that the specialists had inhabited before. I want to also point out that currently only 50% of youth ages 6 to 17 who have clinically significant behavioral and emotional problems actually get treatment right now. So there is a huge gap that we need to fill. And we are the ones seeing patients earlier on. And so we have a real opportunity to screen for issues, to identify the problems early, to connect patients to care, ideally integrated within our pediatric primary care practice. And our primary care settings are also less stigmatized than specialty mental health settings often are. So we have a level of access that many of our specialist colleagues do not.
So that's great. So you're really saying that primary care is uniquely positioned to handle this crisis as it is. And Dr. Nasser, is there anything you wanted to add?
Yeah, I can't stress more the importance of primary care. So primary care has been really the default mental health providers for children and youth, just because of the access issue that Dr. Jung mentioned. And because of what you mentioned also as and the American Academy calls the primary care advantage. We have that long-term trusted relationship with patients and families, and we do a lot of the screening, and we have access to those families and children. And it is definitely less stigmatizing. The approach that primary care has taken or we have taken in primary care in 10, 15 years to increasing mental health access is the integration model. And the integration model is there's like different levels of integration, so to speak. One would be just having somebody in the community that that you refer to having a mental health provider in your practice that you can refer to the highest level of integration, which is actually increasing the capacity of pediatricians to address mental health problems, at least initially. I always use the example of other conditions that we see in primary care. So for most of the biomedical conditions that we see, we in primary care are able to deal with, 80% of them in primary care. And we do refer those children who have complicated conditions or who need further specialized diagnostic and specialty treatments. And the same thing, I think, is true for mental health. The pediatricians, because of also our very strong developmental perspective to children, which really is critical if we are really to make a difference in mental health. Having that developmental perspective and looking at what are the factors that predispose to this, which would help us not only in management of some of those conditions, but also in going a little bit upstream, early detection, and also hopefully prevention. There is science now to guide some of the interventions that can be easily administered in primary care. We just have to find a way to to make them scalable and easier to administer in primary care from an administrative point of view. But pediatricians also, research shows that similar to what this poll indicates, is that many pediatricians perceive that they can do more. They just have not received any training. And then definitely the practice model of fee-for-service individual care episodes does not really support that very much. So I think that hopefully this attention is going to try to move us all as a general profession to actually be able to address this in a more practical way.
And as a follow-up question, because I see a few coming through the Q&A box right here. As a follow-up question, how do you engage the team, your team, to be able to address some of these issues? One person in particular was wondering, what's the role of the LPN in all of this? How do you engage those other team members to help you address these issues that are presenting in your office?
Well, the thing is, I think that once the physicians and the practice decides that this is really our problem, I have a strong belief that people are very resourceful and will really find ways to engage. So I do a lot of interventions. Did receive a little bit of extra training in mental health. So I do see a large number of children with mental health, and I do diagnose and provide behavioral intervention in addition to a little bit of medication. So because I'm comfortable with that, I think a lot of my colleagues who practice with me also became more comfortable, and our nurses became more comfortable because we are addressing those things. So people usually adjust. I think this is what we're going to see in the next 10 to 15 years, I hope, in order to get on top of this problem, is that more and more of this management and diagnosis and prevention and early detection, and really us taking ownership of this problem, that more resources, more research, more approaches to making this doable in the primary care setting. I just want to mention something. 20 to 25 years ago, and those who have been in practice this long will attest to the fact that the types of patients we see are entirely different. 20 to 25 years ago, we still saw a lot of infectious diseases and ear infections and a lot of just biomedical conditions. And now a lot of what we see is really mental health and behavioral health and developmental. I want to just put a plug in for also the developmental issues, because again, the shortage of pediatricians, the shortage of developmental behavioral pediatricians is really pushing this in the care of those children into the hands of general pediatricians. And there's a lot of emerging research to try to address this issue too.
Great. That was a perfect answer. And that kind of leans in, I know, to the next question I have for you, Dr. Nasser, which is, how can the PCP promote mental wellness and prevent mental health issues in their patient population? And this actually goes to both of you, but Dr. Nasser, if there are any specific examples in practice of things that you all have done to take some preventative measures with your patients, I think that'd be great to share with the audience as well.
This is really a great question, and I'm very happy to answer, because really we have some things to offer, or science is actually providing us with some things to work with. So I want to say that if there was something, one thing that we learned in the past few decades of research, is that relationships are probably the one and single most important factor that is absolutely necessary for building good mental health in children. A lot of research has been happening in this area in early childhood. The importance of safe and stable, nurturing relationships in the development of emotional and social competencies in children that would allow them to grow into problem solvers and have good mental health. But this is really across the lifespan. Some of this literature actually is still outside medicine, where we know that even through adulthood and old age, people with better mental health, the single most important thing is those strong, stable, loving relationships. This is not like soft, um, touchy-feely thing. This is science. Children, for them to develop appropriately and to have good mental health and good resilience, the most important aspect is to have this strong relationship with at least one adult who actually loves them, and they feel that this person supports them. That really builds in their and values, and makes them feel that they have value in life, and prevents this sense of isolation and loneliness that really contributes to a lot of the mental health problems in children. We know that the absence of those strong relationships is really toxic to the development, derails development, and turns any stress into a toxic stress. A person needs somebody to buffer the stresses, and this is really this relationship. So this really is the foundation of really what we could actually give to the parents to work with, is that you just want them to understand how important that the parent continues to have that strong, nurturing, loving relationship. Yes, they have to put limits and enforce rules. However, the child needs to always feel that this parent has their back, and they love them and they support them. And if we think about like the origins of really the mental health crisis, it's when this modern lifestyle that we have, and I don't want to sound like I'm blaming anything in particular, but the changes in the social environment over the past several decades really limited the opportunities for building and maintaining these relationships, not only with parents, because now parents are working, both parents are working, and they're working longer hours, and they have less emotional availability to support the children, but also the loss of the relationship with other people, the extended family, the mentors, the neighbors, and so on and so forth. And those provide the safety, the emotional and social safety net for emotional development in children. So again, this is evidence-based, and this is something that we all pediatricians, this is very, very intuitive to us. I don't think anybody could argue with or question this. And it comes really intuitively to us as pediatricians to promote this stable, nurturing relationships with parents that is responsive to their needs and responsive to their developmental tasks that they're going through. So I think that this is something that we can do in practice. I think that in the future we will be looking at more formalized model or maybe scalable interventions that would help deliver this message to the parents, maybe parent training, or any other programs that would make sure that these children have access to those supportive relationships that are so essential for their development and mental health.
That was a fantastic answer. And I see a lot of folks are sending in more questions, kind of either agreeing with your sentiment, but also wondering, I think it's really great. So I think just to make sure I heard you properly. So currently, right now, the addressing the mental health crisis is really falling on the physicians and the care team. But what you would like to see in the future is also giving the tools and resources to the parents to be able to also help out at home, right? Because I'm assuming there's only so much you can do within your office setting, but giving them the tools to be able to help them at home, I think is valuable, especially since there's that trusted relationship, right? You have the trusted relationship with the family and the patient, but then that parent also has that trusted relationship with the child.
Yeah, this is true. I mean, the thing is, we started talking about this in the context of what can you do to prevent this.
Right.
And even, I think we could even do this as an intervention in a child who's struggling a little bit. Now, when we're talking about a kid who has a diagnosable mental health, who's really in severe distress, is suicidal, or is diagnosable with depression, those definitely need specialized help and may need psychiatric help and may need medications. And all of this is all well and good. But still, the importance of the relationships, what we call now relational health, is so critical to the development and the building of resilience and good mental health in children. This is science. This is something that we have to instill, and we cannot deliver this. Parents will have to deliver this. Now, lucky enough is that we pediatricians always work through parents. We are partners. Our parents are our partners in the care of children. We do not expect to do everything for a child with diabetes. We diagnose, we treat, and we send them home, and the parent will have to do a big part of the work. Same thing here. And lucky is parents are really built in and programmed really to love their children. And this should come not as a chore to them. It might be a little bit of a challenge just because of, again, the lifestyle that does not leave really much time and opportunity for these. But I think parents are resilient and resourceful once we equip them with this information, and they understand really the importance of them being there for that kid, being that nurturing person. Sometimes the nurturing person is not the parent. It could be a grandparent, it could be an aunt, an uncle, a teacher, but the child needs somebody to love them and feel that they support them, and that really prevents a lot of mental health issues in the future.
Great. Dr. Jung, I was wondering, if you wanted to chime in with anything additional, please feel free to do so. But if not, how can the primary care provider identify and treat these mental health concerns in their patients? What are some tools that folks can use to help when someone presents with some symptoms in their office?
Absolutely. I think Dr. Nasser did a fantastic job of speaking to the importance of those caregiving relationships and setting the foundation for a life, just lifelong mental health wellness, but also physical health too, because we know just the inflammatory effects of prolonged and what we call toxic stress can lead to asthma, cardiovascular disease, other things, and not just mental illness. So once we are suspecting that there may be some issues going on, there are a number of screening tools that we can use. But even in the absence of clinical suspicion, because many youth are reluctant to talk about these issues, both Bright Futures, the AAP Bright Futures guidelines, as well as the U.S. Preventative Services Task Force, call for universal screening of mental health conditions at certain critical points, aligned with well child care touch points. So during infancy, we are called upon to screen for maternal postpartum depression. And this speaks again to setting that early caregiving relationship up for success, because a depressed mom has a much harder time responding appropriately to her young child. A relatively recent recommendation has also been from the U.S. Preventative Services Task Force to screen for childhood anxiety, starting from the age of 8, and that's a recent one. I think more of us are familiar with the call to screen for adolescent depression, starting from the ages of 12 and up, along with adolescent suicidality and substance use, with tools like the PHQ-2, the ASQ, which is a suicide screener, as well as the CRAFT and the HEADS for substance use and other risk behaviors. We can also use like the PHQ-2 or the GAD when we have clinical suspicion of like an anxiety or depression disorder. There are additional screening tools that I go to all the time. For younger kids, there's one called the SCARED. It's a great one for anxiety. There's a caregiver report. There is also a youth self-report starting from the ages of 12 and up. And also, as most of us are also familiar with the Vanderbilts to screen for ADHD symptoms when clinically indicated. Okay, so after we screen, we have to do some triage. And the resources that we're going to send out afterwards to all our participants include some thoughts about how you then take PHQ scores, PHQ-9 scores, or GAD-7 scores, along with clinical history, really speaking to functioning of the patient, to assign severity. Is this mild? Is this moderate? And is this severe? And then everything else we do afterwards really depends on the severity of the symptoms and the functional impact that these symptoms are having on our patients' lives. And so for very like mild symptoms, we can talk a lot about lifestyle guidance. Okay, so I push exercise. So exercise is good for mood. It is good for stress and anxiety. It is good for attention and focus. It's great for emotional regulation, and it's great for your heart, right? Good for your brain, good for your heart. It's fantastic, and especially like sports or other social activities brings in that aspect of social connection that is so often lacking in the lives of youth. And so for milder cases of depression or anxiety, I will often push exercise, good nutrition, good sleep routines, participating in some sort of like peer activity, like the natural social groupings that are out there. Sports aren't your thing. Like there might be arts activities or performing arts activities, dance groups, other things that can get you out there and involved with other youth and other positive adults in their lives. Scheduling something fun. So this kind of active monitoring and lifestyle support, and then calling them back in, not for like that 1 year well child visit, but calling them back in like a month or two, checking in, seeing how they're doing. Just the active interest and involvement of their primary care doctor in their lives, asking about these things, is often therapeutic, and it will help many of the youth. And there will be some who just get better with that, and then some who may progress on and then need more. Then for moderate and more severe forms of depression and anxiety, there, of course, are evidence-based psychotherapies, such as cognitive behavioral therapy, medication, and for ADHD, of course, are stimulant and non-stimulant medications. We don't have time to get into what all of those are here. I would encourage people get some training. The American, if you have not gotten this kind of training, like the majority of practicing pediatric primary care providers out there, the American Academy of Pediatrics does have a range of wonderful mental health care training resources. And that website is also on our list of website resources that we're going to be sending out by PDF afterwards. There's the Mental Health Minute that has very short lectures. There are ECHO courses that allow for like more prolonged engagement and involvement, as well as like day-long courses or weekend courses that really like build up those skills. So I encourage everyone to check this out. Finally, if we could pull up the next slide, please. It can feel easy. It can be easy to feel alone in this effort, that we are out here drowning and struggling to meet this need with not enough time, not enough resources, and not enough training. But increasingly, pediatric mental health care access programs are expanding across the country, in part with funding from HRSA. And the states that you see here in color have some version of these pediatric mental health care access programs available. And what these are, pediatric primary care provider can get on the phone, call a psychiatrist, and ask for help diagnosing and managing mental health conditions in their patients. And I am helping to direct one of the programs here in Northern California. We also offer continuing medical education. Many times we offer help with care coordination. Many times we are able to expedite specialty mental health consultation either with a psychologist or with a psychiatrist when there's an off-ramp needed and especially the intensity needs to kick up a notch.
Great. And Dr. Nassif,
If I may add something here, this is really a fantastic overview of all the screenings. The only one thing I would like to add is uh, considering the developmental and environmental underpinnings of many of the mental health problems in children, and taking a trauma-informed perspective, I think screening the family for um, uh, um, stressors or factors that we know impact children's mental health is really important. And there are some of those screeners that are routinely administered in a lot of practices now. It's becoming very standard of care now, including screening for, poverty, food insecurity, domestic violence, and substance use in the parents, and so on and so forth. And I think that really is important, because if we are going to leave that child in that environment, we need to help also the parents. This is a family, family-centered care, basically, because the child still, unless in cases of severe abuse or neglect, the child is still under the care of that family, and improving the functioning of the family and helping them help the children is really would be what would be important to screen for, and also have some resources available to provide for the parents. And then just one plug in for the follow-up. I think it's just so important that when you detect something and you give a recommendation or a treatment or whatever, or even if you're watching or whatever, bringing this kid back in a few weeks, just to let them know that you're just not blowing it off. You really are interested in following up. This really just goes a long way in reassuring the family that you're on their side, and that the kid, that you are interested in them and in their well-being. I just have a thing for this follow-up. I think it's super, super important.
No, that's fantastic. And I agree. Follow-up is very important, especially for this particular population. So I do see there are a few more questions that have populated in the chat. So I'm going to switch us over to just kind of taking some audience questions, and we can just kind of go back and forth for the end of our time here. We have about 15 minutes. So one of the questions that came through the chat is, how have you seen things such as the violence in schools, lockdowns, and gun violence impacting children today in your office when they come to see you? Is that a topic that comes up? Is that something that folks are worried about? How have you been addressing that in your practice? And we can start with Dr. Nasser.
So yes, especially really for young children or those who have an anxious personality, having that threat definitely can drive up their anxiety. So it does come up sometimes. It produces anxiety also in parents. But this is really, the not million, the $1 trillion question is how really to address that. But it is really very, very important. So that's about gun violence. What was the other thing you mentioned at the beginning?
Just violence in schools in general and lockdowns.
Yeah. So lockdowns really have variable effect on children. For some children who the school environment had been stressful, actually, there is research to show that they actually did better because, and those are the kids who also resisted going back to school, which is not necessarily a healthy thing. But yeah, isolation, social isolation, and we know how important peer relations are for children, especially pre-adolescents and adolescents. Those do have a negative effect. And what we have seen is that this kind of exacerbated their dependence on social media for connection. And we know that social media does just not do the same thing that real social connections do, if actually in some situations they're downright harmful. So those are the aspects that we really see parents sometimes are reluctant to limit the social media use or the screen use in children because they feel that, that's only social interaction that they have. And rightfully so. However, we don't know really that that's the social interaction that's beneficial for them. So it's a dilemma.
I would say it's a dilemma. And then another question just came in about the role of social media and internet use. How has that played out with your adolescent patients? And this can be answered by both of you. So I will let Dr. Nasser, since you started, you can quickly give a response, and then I'll kick it back over to Dr. Jung.
Yeah, so I think that for social media and for screen use, again, I go back to the parent is your partner, and you want to just discuss that the parent will have to really monitor the content and monitor the volume of use, and work some kind of an arrangement with the child to decrease, and also realize that if they are not doing social media, then they will need to provide them with other activities to do. So I think this is really, I usually invite families, both parents and children, to just have this dialogue, just have a family meeting, have it, hash it. It's not going to happen overnight, but when everybody is having that discussion, everybody's on the same page of what the thinking is about this. I think that would be our best bet to getting a reasonable arrangement, and also with the use of the technical and technological monitors and time limits and so on and so forth, that those can be helpful.
Great. Dr. Jung, anything you wanted to add?
The American Academy of Pediatrics CAP has like a family media guide. So there are some resources available to help guide that family discussion around positive screen time and limits on screen time. I also want to say it's helpful to have some family routines where you carve out time that is screen free. One of those could be like the family dinner time, which like for many has been a casualty of our busy lifestyles. But that time together of just checking in together, eating together, and leaving that time screen free, like all screens aside, so that you can actually just pay attention to each other. So to carve out those spaces for connection that are free from screens. The other practice that I often quote unquote prescribe, and many times in cases where behavioral problems have started to surface, there's something called special time. And it really banks on the power of undivided parental attention and attunement, and carving out time and space for that. So it's scheduled time, it's every day. It could be brief, like 10 or 15 minutes. No distractions. The whole idea is undivided parental attention. Child picks the activity. And the whole idea is to have fun together, not looking at a screen together, but to do something interactive that the child likes to do, and just enjoying each other's company. And this is not the time for correction or for like performance or anything else. This is really about connection. So positively creating those times of connection that are screen free and building that into the routine, I think is very helpful. And finding other positive activities that can go into that routine, whether it's like after school activities or times at the park, as structured or unstructured as fits for the family's lifestyle. Also very helpful to think about, and that naturally then will prevent the need, the boredom that often turns kids towards the screens. And finally, I want to add that part of the routine is like a regular sleep time as well, a regular bedtime, and trying to keep those screens out of the room when it's time for bed.
I think those are all great suggestions.
I push cooking to my parents. I go as far as giving them copies sometimes of cooking magazines to see if they could pick recipes and try together. I think this had so many positive, interactive, and activity styles. When kids learn to cook, they are proud, and they feel confident, and then they also it has the advantage of them seeing what really goes in the food, and then eventually actually coming with a product that's healthy and not super processed that they can get in the store or in a restaurant. So this is one concrete activity that I usually try to suggest and explore parents and children's interest. Sometimes you have to kind of they might not embrace it immediately, but and sometimes it just might take a process. But then one day you'll be surprised. They come and tell you that they're interested in cooking or something like that. So I think that this is just my plug for one of my favorite things. I like to cook, so I think it's a great activity for families together.
Yeah, no, that sounds like a great way to do family engagement. I really like that. So I know we only have about 10 minutes left of our time, and a few more brass tacks questions came in about sustaining behavioral health care in your practice. So everyone on this call seems to agree that addressing the mental health crisis is very important and needs to be done, and this work does fall on primary care to do so, specifically in pediatrics, pediatricians and their care teams. But they want to know what kind of funding is available to help them get started if they're at the beginning of their journey. Are there models that you all are employing that have worked for your organizations that might be worthwhile? Someone suggested some grant opportunities. So just talk about a few of the different avenues maybe that you have tried or that others have tried.
So our practice has relied on some philanthropic grants in setting up systems to start, whether it's screening for addressing social determinants of health or trauma in our practice. It allowed for protected time to set up those systems and to do the training. And that has been local private foundations in many cases. SAMHSA, for those who have the capacity, larger health systems that have the capacity to go for federal grants, SAMHSA and HRSA has sometimes put out some grants in this field, sometimes smaller grants that get at developmental screening and promotion in practice, or in addressing mental health needs, particularly the SAMHSA grants, which tend to be more regional. But those often call for a greater level of collaboration with other local systems. So it's a collaborative effort, and you're kind of larger systems going for these grants together. And that may or may not be within the reach of, say, your typical sort of practice. So something smaller scale, many times it's the philanthropy where you might start. And the bigger question about how you sustain this. So a lot really depends on the payment source and who your payers are, because mental health parity is the law of the land, but it's been very, very difficult to achieve in practice. And so those who have successfully integrated behavioral health in private practice will say it takes commitment on the part of the leadership, because it's not going to be money making, right? And it may be money losing to some degree, but you can at least partially sustain the salary of an integrated behavioral health clinician through clinical billing on the part of the social worker who's doing psychotherapy, for example. Sometimes they have been creative and arrange just paying for psychiatric consultants to come in at certain times to kind of help see some of their patients and making those arrangements. And Medi-Cal, which covers about between Medi-Cal and SCHIP, which will cover about half of children in the United States, roughly, give or take, it is next to impossible just because the payment rates are so low that most therapists out there will not take those rates. Many psychiatrists will not take those rates. And so you're then relying on the public health system, whatever your local public health system is, for mental health care. And we know just how difficult that can be at times. But I think this speaks to the powerful need for advocacy on all our parts as professional organizations, as physicians, as especially mental health providers, and everybody and anyone in between, patients and families, to advocate for a more robust system. Substantial federal investments have gone out to try and help to make this happen, but it takes some time for this to trickle down into local reality.
I have a couple points on this. In addition to agreeing with all of the above, I think this is a great discussion on that subject. But one is, I really think that we that in the next, I don't know how long it's going to take, but payments models will have it. This is a national crisis, and I think with time we will be able to, with advocacy and all of the large organizations pushing for that there will be improvements in reimbursement, and that would really be very, very helpful. And then the last thing is one strategy that I use, and I don't know if the audience is familiar with the Medicaid change in primary care reimbursement that went into effect in 2021, that allows the pediatrician to bill just for time for any visit. And that would also that you could bill not only for face-to-face patient encounter, but also for care coordination and documentation. So that allows us to really a little bit get at least some reimbursement for those mental health visits that will take a longer time. It used to be that you could just, there's a maximum for how much you could bill for that, but now you could bill for as much time as it's going to take you. I don't know that this is comparable to, doing other types of visits, but it's still at least something that I certainly use a lot with my practice. So this is how I bill for any kind of counseling or developmental evaluation if needed, because it takes 6 months to get it with a developmental behavioral pediatrician. And those visits typically take a lot longer than your average 15-minute, half hour, or even 45 minutes at times. So this is a strategy that one can use to on the local scale, on the individual scale.
Great. And I will also point out the BHI Collaboratives does have a few pre-recorded and released webinars on billing and coding. We have a billing and coding 101. We also have one that's specific to the collaborative care model that we are more than happy to share links to as well. And you can also find it on our YouTube channel. And I know we're getting to the top of the hour, so I am going to say thank you again to Dr. Nasser and Dr. Young for joining us today. This has been a very eye-opening conversation, and I know we have a lot of questions that came in from our audience. So again, thank you to all of you for submitting your questions. The questions we didn't get to, we will take a look at and see if we can get resources and responses back out to folks. So again, thank you for your time today, and have a great rest of your afternoon.